So hi, everyone. My name is Ayan McGee. I'm the Associate Project Director with the CARE TA Center. For folks just joining us, please do drop your name, organization role, and county into the chat just so we can say hey. Thank you so much for joining us in this continuation of the cohort coaching series, Crisis Now Mobile Crisis Outreach Team, Essentials of Training Mobile Crisis Outreach Teams. Our esteemed presenter, Jamie Seller, Chief Strategy Officer with RI International, will be leading us today. But before we jump in, we just want to move through some quick housekeeping items and briefly introduce the CARE TA Center. Next slide, please. So first off, just a quick disclaimer, this training is offered through the Crisis and Recovery Enhancement CARE TA Center, which is funded by the California Department of Healthcare Services and administered by the Center for Applied Research Solutions. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the California Department of Healthcare Services. So the Crisis and Recovery Enhancement TA Center provides a comprehensive array of training and technical assistance services to California's Mental Health Services Act funded stakeholders and partners to strategically plan, implement, and evaluate their behavioral health coordination and crisis response efforts. Next slide, please. Our center is a collaborative of experienced partners with collectively a well-rounded knowledge base of the crisis continuum. This includes CARS, Recovery International, RI International, who's here and presenting today, NAMI, California, C4 Innovations, the Research and Action Center at Impact Justice, and Stanford Sierra Youth and Families. Next slide, please. As noted before, we offer a comprehensive training and technical assistance array of services, including listening sessions, our resource library, quarterly newsletters, and content digests. Our annual conference will be coming up this May 25th, and you can find all of this information and more on our CARE website. Next slide, please. And so that brings us to today. Thank you all again so much for being here for our session, Mobile Crisis Outreach Teams, talking about the essentials of training mobile crisis outreach teams. And with that, I will pass the mic over to my wonderful colleague, Jamie Seller of RI International.
Yeah, I appreciate it. I'm gonna, hopefully everybody can see me and hear me. I'm always concerned the technology is gonna go ahead and fail, but I'm gonna go ahead and talk a little bit about me and why I'm actually doing the presentation today. So my name is Jamie Seller. I'm the Chief Strategy Officer at RI International. So it's a lovely title, but by training, I'm a licensed professional counselor. And in my role as Chief Strategy Officer, I'm doing consulting both nationally and internationally around crisis system development, crisis system space. I've been working really for the better part of 35 years within crisis systems. And one of those positions that I had, fortunately enough, for years and years and years and years, was running the mobile teams in Maricopa County. Maricopa County's got 4.4 million people. We were running 24 mobile teams a day, two-person team, 10-hour shifts with a clinician and a peer. And though they were one of three agencies that were seen in the Crisis Now white paper that came out in 2016 as being kind of an exemplar and kind of a model to emulate as far as crisis system mobile responses. Fortunately, at that point, I got recruited to come over and work at RI International, work in operations for facility-based services, remain true to the Crisis Now model, and was actually fortunate enough to be one of the writers for the SAMHSA's national guidelines came out in 2020. And really what you're going to see is my fingerprints all over the sections around mobile teams, really describing some of the work that we've done. So what I'm going to talk about a little bit today is a lot of those leanings that come straight from SAMHSA's national guidelines. But once again, I understand that a lot of the work that went into SAMHSA national guidelines came out of my personal experience running mobile teams here in Maricopa County, once again, for years and years and years. And I know it's tough to talk about how many years I've been in the field when I still look so youthful and so young. But just know that, you know, any challenges you may be having right now, chances are I probably have kind of been through that and either found some successful options to go ahead and fix that or didn't. So today we're going to talk a little about what I've done, what I haven't done, what works, what doesn't work. But the presentation is really just a kind of an appetizer to be able to start a robust and vigorous conversation after the presentation to really be able to provide more specific answers to questions, ideas, thoughts, and utilize the collective knowledge of the group that we've got today to kind of move forward. So that's a little bit about me and why I'm here and what the goal is going to go ahead and be. So let's jump into a presentation. We'll do a little bit of talking about something that's very exciting, which is training for mobile crisis teams. I'm going to highlight really what the basic crisis training elements are going to be. We can certainly talk about what the modules would look like and what goes into those specific modules. But really what I'm going to highlight is the types of modules that you're going to go ahead and need. Out of the basic crisis training elements, I'm going to highlight the ones that are going to be mobile crisis specific. I'm going to talk a little bit about a timing or a timeline for training. And then finally, a few tips and tricks and thoughts that I've got at the end, just go ahead and think a little bit more about training. So as we're thinking about training, understand first and foremost that there are three types of training that you end up doing at agency-based mobile crisis outreach teams. One is going to be agency specific. That's going to be all the stuff that you need to do to be a good employee of the company that you work for. How do you clock in? How many sick days do you get? What's the process if you need to take extended time or FMLA? Who's your HR manager? When's the pay cycle coming? What's the your culture? What's your belief, mission statement, vision statement, and so forth. I'm not going to go into that much more than what I just did, just because every agency is going to have that. I don't think it's really applies specifically to mobile teams. The other is going to be crisis theory specific. And when we talk about that, we talk about things that are going to really be applicable to anybody that works crisis. If I'm working a crisis call center, if I'm on a CIT team as a law enforcement officer, if I am, for example, working facility-based crisis work, if I'm working inpatient psychiatric hospital as an intake coordinator, somebody determining a level of care needs. These are the types of things that you need to know. And then there's going to be some trainings that are going to be really specific to mobile crisis outreach teams, things that I need to know when I'm doing street level work out there in the community. So we're going to go ahead and jump into crisis specific theory. And I'm not going to jump in too much on this. What I'm going to go ahead and talk about is the need for a model. So if we really think about models of crisis work, I'll go back to what John Franklin Sierra, who works for the CEO office in LA County, says. He really says all models are useful. All models have flaws. Some of them can be useful. So as you start to think about your agency, start thinking about, do you have a model that you utilize on crisis theory? Why people go into crisis and how you support them in getting out of crisis. There are a few that are out there. We've got, as you can see, Robert's 7-stage crisis intervention model, critical incident stress management, you've got mental health first aid, you've got therapeutic options, CPI, ABCD. There's a host of crisis theories out there. And quite frankly, I'm not going to tell you which one's best or not. I'm going to tell you the one that I use and the one that I like, and I think it matches up fairly well for mobile crisis teams, and it is that Roberts 7-stage crisis intervention model. So if we can jump a slide, I'll just kind of show you a little bit about what it looks like. So the reason that we end up having a model is so that our staff and our leadership have a common way to go ahead and communicate about what they're actually seeing out there in the field, and they have the ability to plan. And they have the ability to go ahead and fall back when times get tough about what they should do next. What you do know, for those of you working in crisis work, is we're working in the gray constantly. Sometimes having a model to fall back on is going to be helpful, but also when we start thinking about training and getting consistency among the staff that we have, if they're all working out of a different philosophy, all working out of a different model, we don't quite get all boats to rise at the same time. Our staff probably aren't getting what they need as far as support. Not all models are going to be created equal. I do like Robert's 7-stage model. Now, the only thing on this that I don't like is I think number 2 sometimes should come in number 1. Number 1 should come in number 2. But if we take a look at it, these are the elements that you should be doing in a mobile team intervention. Now, in session 6, I'm going to actually talk about the components or the elements of a successful mobile team intervention. And I'm going to actually relay it back up to Robert's 7 stages and how they kind of match up. Not perfect, but they match up fairly well. So as you're thinking about your agency, think about whether or not you've got a unified field theory on how we're going to go ahead and support our teams out in the field and give them a model or a base to go ahead and work from. And I do know that it gets difficult. When I went through my master's degree, I was taught 9 theories of personality. And at the end, I asked, which one's right? And the professor looked at me and said, well, which one do you kind of resonate with you? Which one do you kind of think is right? And that's really what we're talking about here. I'm not going to say one's better than the other. I'm saying this one's useful, and models need to be useful, even if they're flawed. And what I can say is this matches up fairly well for mobile crisis, and it may not match up very well with everything else, but this is the one that I tend to like. So teaching this model would be very, very helpful. Like I said, then when you are hard baking this into your work, you can kind of talk about it in a way that makes sense. So you can start to ask questions of your team. So tell me how you establish rapport. Tell me when you were exploring alternatives, what did you hear from the client? What was your follow-up plan? So these are things to kind of think about. Go ahead and do your research on your own, but know that this one works. So yep, we can move forward. Thanks. So there's also crisis-specific theory. Once again, when we're talking about crisis-specific theories, we're talking about some of those crisis mental health issues. They're going to go across a wide variety of disciplines. Mobile teams, certainly. Call center, yes. Facility-based services, you've got it. Case managers, ACT teams or FSP teams in California, absolutely. So these are the things, as you are creating your program or your training manual, you need to have something on this. I need to be able to talk about suicide. I need to train my staff in ideas around suicide. And that could be any number of things. It could be the ASSIST training, which can take 2 days and very structured. You can train on the interpersonal theory of suicide. You know, Dr. Thomas Joyner's work out of Florida State University, Zero Suicide in Healthcare. There's a lot of them out there. What I'm suggesting you do is find one that you like off SAMHSA's evidence-based practice kind of training modules. They're what they're talking about, and go ahead and start to employ it within your agency so that everybody that's seeing somebody has some kind of training that you can document, you can go back, that you can verify in suicide, because quite frankly, we're going to see a lot of people out there with suicide. That's a potentially life-threatening issue. We also need our staff to know about suicide or substance use disorder. You know, active use considerations, withdrawal considerations, ASAP placement criteria. What we tend to find is a lot of folks may be really good in behavioral health, they may be really good in substance use disorder. They don't have that cross-pollination. They're not really integrated. They're really good at one or the other. You've got to make sure that your staff are going to be generalists and can work with somebody who is currently intoxicated, somebody who might have potential for withdrawal, somebody who might have some suicidal ideations or a combination therein. So you want to make sure you do have some training on substance use disorder. We want to make sure that all the work we do is trauma-informed. Generally, most agencies are going to have trauma-informed care protocols and policies and trainings already in place. Absolutely, you can piggyback that. There's nothing that's going to be mobile team specific that's going to be different than general trauma-informed care, but you definitely need to make sure that all staff across continuum have training in that, because once again, the overwhelming majority, if not everybody that you come into contact, is going to have some trauma history, depending on how we define trauma. Let's move forward. The other thing that's going to be real important is going to be able to use risk assessments. And as we'll talk about in session 6, we'll talk about triage and screening, and we'll also talk about assessment. So having the tools in your disposal are going to be absolutely important. And what we realize is that most people, even most behavioral health professionals who have been working in the field, really have not had a lot of access or a lot of use for some of the risk assessment tools that are out there. What I am going to recommend is, if you are using a risk assessment tool, and you need to, that you should be using probably the Columbia Suicide Severity Rating Scale. The Columbia is quick, it's easy, it is probably the most common out there. It is easy to train to, and it's got a lot of validity to it. So when you're looking at your teams to be able to make assessments on risk, it's going to come back to clinical decisions, but having your documentation that supports the reasons for your final decision is going to be important. And what I can tell you is that Columbia, in a down and dirty way, is quick, fast, effective, fairly easy to do and fairly easy to train to. But there's others out there, you know, that we need to look at risk assessment. Beck scale for suicidal ideation. Got to be able to assess for detoxification, alcohol SUD issues. So we might be looking at the TAPS-1, the TAPS-2, or the S2BI, screening to brief intervention. But you got to have risk assessment tools that are in place. You've got to train to it. You've got to make sure that they can demonstrate competency over it, and you got to make sure that they're utilizing those out in the field. I believe that we need safety and risk collaborative action planning. It's actually the final stage in the timeline for a crisis intervention. But you need one that's evidence-based. And what I can tell you right now is Stanley Brown, their safety planning, collaborative action planning process is probably the most utilized that's out there. It's evidence-based. I'm doing work in Australia. We're actually utilizing it in Australia over the safety planning that is most commonly prevalent in Australia. And RI actually right now is working with Barbara Stanley to go ahead and pilot the use of the Stanley Brown being done by certified peer support specialists as opposed by just clinicians. But once again, it's easy, it's down and dirty, and quite frankly, it hits about 4 of the elements that you need in a successful mobile team intervention, which we'll talk about in a couple of weeks. I also want other patient placement tools as appropriate within my system. I know a lot of mobile teams that are going to leave it back to clinical judgment as to what level of care a person needs. And it's always going to come back to clinical judgment in the end. But I want my documentation to align pretty well with what my final recommendation of the team is going to go ahead and be. So if we take a look at the 2 across the country are probably most utilized for behavioral health, it's going to be Locus and Interqual. Locus is the level of care utilization system. It's been given over 1.4 million times in the state of Georgia over the last decade. So very prevalent. The data, you can start to see how it skews. You can actually start to benchmark what some of that national data is versus what you're seeing for your mobile teams to kind of see how it aligns up. But once again, if you have a locus and that locus says this person is safe for outpatient therapy and your therapist or your clinician says somebody's safe for outpatient therapy, probably pretty safe for that intervention. If there is a disagreement between clinical opinion, clinical thought, and what the assessment tools and the patient placement tools are doing, then that's an opportunity for supervision. But I need to pick one, and I need to train very well to it, because there is nothing worse than having staff utilizing a tool that there is no documentation that they were trained on, no documentation that they meet whatever basic competencies you're going to have for your agency. And once again, ASAM is absolutely, love the ASAM criteria, specifically around that SUD work, much more than Locus or Interqual. But like I said, I just don't think it translates as well over to the behavioral health issues. But having your staff trained in Locus or Interqual and ASAM is going to be important, and it doesn't take a ton of time. So let's move forward. So depending on kind of where you work and what if you're urban, if you're frontier, if you're rural, you're probably going to have mobile teams that need to be generalists. And by that, what I mean is in Maricopa County, we've got specific teams for child and adolescent. We've got specific teams for veterans. We've got specific teams for folks with intellectual and developmental disorders. But the overwhelming majority of our teams are going to be generalists. They might go see a 12-year-old, and then their next call might be a vet. And then their third call could be somebody geriatric, and their fourth call of the day could be somebody with an intellectual and developmental disability. Definitely what we need to do is do population-specific trainings, just like we're using cultural competency, just like we think about trauma-informed care and all of the work that we do. We want to be able to go ahead and meet the needs of very specific populations, because our staff need to be generalists. Because if I've got 7 different teams and they're all specialized in something different, and I get 2 calls for children, but I've only got 1 team, that other team is going to have to go out there. I need them trained as well. These are the ones that in Maricopa County we do train for grief and loss, homelessness, psychosis, relationship issues, health, veterans status, LGBTQ, clinical skills across the lifespan. So we might go see a 5-year-old, we might go see an 85-year-old. And we're going to go see folks with intellectual and developmental disabilities. Now, you may say in your community that you've got some special populations that need to be served. Absolutely appropriate to make sure that your teams are trained well enough so that they're competent and confident when they're going out there and working with somebody. I also believe that there are some skills and techniques that we can go ahead and give staff. They're not self-actualized when they come to us. They might have a master's degree, they might have their state certification as a peer support specialist, but we don't know what their skill set is in actually helping, supporting, engaging, and working with others, or developing even that therapeutic alliance. So some of the things that we would train to in Maricopa County would be how to develop rapport and how to develop support. So really what it would be is what we call patient engagement. We utilize a model called AIDIT. AIDIT is actually fairly easy. It stands for acknowledge, introduce, duration, explain, and thank you. It's a way to go ahead and engage people in an appropriate manner when they're in crisis. That really is going to go ahead and talk about how we create expectation, how we spend our first 5 minutes, how we go ahead and describe what's going to happen so that there's no surprises. It really does help decrease agitation. It also increases compliance with those that we work with. And what we do know is that less anxious, more compliant guests or clients that we're working with, generally you're going to tend to get better outcomes. So this is kind of a medical model of interaction, really utilized well in emergency departments, but I think it works very well out there in crisis. I do a 1.5 hour aided. That's about 45 minutes of explaining the concepts and about 45 minutes of folks telling me they understand and going ahead and role modeling for it. Fairly easy. There is evidence to support it. And once again, you can almost create your own fairly easy, just looking at material you can get off the internet. Anything that's going to be around skill coping mechanism building. I like to teach mobile crisis teams motivational interviewing, because once again, in a 75 to a 90-minute intervention, half of my goal is encouraging, supporting, and helping them realize the benefit of being an active participant in their recovery in order to go ahead and take the next step. So once again, as staff are coming to you, they may have different levels of expertise, different levels of experience, different levels of education. But what I can tell you is not all staff are built the same. You need to make sure that your training is getting them up to the basic minimum standards and making sure that if they're not natural at the position, that they're going to be at least more natural within the position that's going through. So these are some of the core elements of specific crisis training that you need to have included. Doesn't need to be long. Grief and loss, I need to spend 45 minutes to an hour discussing that. You know, homelessness, I might need to spend 2 hours. Psychosis, I might need to spend 3. Relationships, I might need to spend 1. Health, I might need to spend 2. Depending on where you live, veterans may be more, maybe less. These are the things that we want to go ahead and focus on. It's got to be in there, but like I said, it doesn't have to be heavy. So you can take 2 or 3 days and cover really every population-specific training that you think you need by doing an hour, hour and a half, 2 hours, 3 hour intervention or training modules. Let's go to the next screen. So these are some of the things that I do think are going to be important for mobile team specific that may not apply to other forms, facility-based or call center. This is the stuff that's when you're doing street level work. One is I certainly need to train to daily operations. And by that, what I mean is, what is the flow? What are we doing in mobile teams? We need to train to our KPI, which is our key performance indicators. Too often when I go and I interview staff in other agencies who are running mobile teams, I'll ask things like, you know, what is the main goal of mobile teams? And I'll get 3 different answers for 3 different teams. What are the key performance indicators that you look to get to show that you're doing actually good work out there in the field? They can't tell me. So really what I want is I want my teams to understand their role, what their benchmarks are going to be and what the indicators are going to be so that they can go ahead and keep a scoreboard for themselves about whether they're being successful or not. If they don't know what the mission, what the vision is, what the goal is, what the outcomes they should be looking for, what success looks like, they're probably not going to be very successful. So you really want to go ahead and during that training start to hammer that in. We need to know things like dispatch procedures. They need to be very much operationalized. They should be something that's just every single time going in the same way. I need to train to charting, my electronic health record, my documentations. How do you check out a van? You know, what do you do when you need the van washed? What do you do when you need to get gas for the van? Who's accountable for the van? Where is the registration for the van? Where's the insurance for the van? How those things work. And supervision requirements. Mobile teams should have higher supervision requirements than general counselors out there in the community. We've talked about that in some of our other sessions. And the focus is we should be training to what those requirements are going to be, including when they need to seek supervision when they're out there in the field. We also need to really have a stronger than average understanding of community resources. So if we really talk about what is the goal of mobile teams, you can go back to SAMHSA's guidelines, but really the goal of mobile teams is to be able to help people currently in crisis, help them resolve their crisis and make them more resilient down the road to decrease the likelihood of crisis in the future. Nice way of really saying my job is to help people stabilize, keep them out of emergency departments, keep them out of the jails, keep them out of the back of police cars, to help them go ahead and manage their current symptoms and get it connected to community resources. They don't go back into crisis. So in order to do that, the overwhelming majority of people I work with, I'm going to need to connect somewhere. So I need to know what my facility-based resources are, what my outpatient support groups. I need to know of where I might be able to go ahead and get some help with some of my social determinants of health, where my housing might be, where I might be able to get food stamps, where I might be able to apply for Medi-Cal, who's got urgent care center aspects of that, where my residential programs may be, permanent temporary supportive housing, occupational support, all of those kind of things. Because quite frankly, if you're only referring to the same 4 or 5 places, you're probably not giving people the breadth and depth of the referrals that they need, which probably isn't going to get you the longer term outcomes that your community is going to require. And people are going to be more likely to go ahead and give you a call in 3 weeks when those referrals tended to fall through. So we spend a lot of time updating our community books, discussing our community books, and even during training, we will go out and actually view those during some of the ride-alongs and some of the field portion of training, which we'll get to in a sec here as well. Moving forward. A few other ones that I think most people miss as they're thinking about mobile teams. One is personal safety. So in Maricopa County, both agencies that run mobile teams do have training on personal safety. It's going to include, where do I stand? When do I go ahead and bring in police officers? How do I manage dogs? How do I deal with bed bugs? Where should staff be standing? Should they enter rooms? Should they not enter rooms? There's a lot that goes into personal safety, but you need to have something on that. If not, you're asking folks to do street level work, sometimes at 2 o'clock in the morning, sometimes the most potentially violent parts of your community with folks that are at their most vulnerable or potentially most agitated. I need them to understand how to do personal safety. We also actually will train our staff in we would use CPI for those of you who are familiar. And we're not going to ever do a physical restraint out in the field, but I need folks to be able to understand how to utilize de-escalation skills for someone severely agitated. I also need them to understand how to block and move. I need to have them understand how to utilize their ban in order to provide additional personal protection for themselves as well. So these are the types of things that absolutely need to go in, because if not, you're going to have scared staff out in the field, and scared staff tend to make mistakes. They tend to overprescribe inpatient. They tend to overprescribe police coming into the system as well. I need to train on interaction with law enforcement. So depending on your community, you're going to have heavy involvement with law enforcement if you're doing co-response teams or if you're embedded. If you are a civilian mobile team, anywhere from 3 to 10% might be the amount of times calls that you are requesting police backup. We will say once you get a little bit more sophisticated and triage is a little bit better, that number sometimes will go down once you start to really sort that through. But how do you work with law enforcement? What are the common goals of law enforcement when they're in their field? What's that interaction dynamic going to look like? Who's in charge of the scene? I've got to be able to support my team in understanding what those dynamics are. Otherwise, they're going to frustrate our partners in law enforcement who are going to stop calling us for support, and it's going to be awkward every time we call them for support. When and how to get supervision. I spent a good 30 minutes of, when you scratch your head, you call me. When you don't know what to do in the field, when you call me. When your assessment and your clinical, when your screenings and your clinical assessment don't match, you need to call me. So really, I spent about 30 minutes of when and how to get supervision and what to do when you're talking with your supervisor and you don't feel like you've gotten what you need, how to escalate it up. We talk a lot about team dynamics, the roles and the scope of practice. Once again, in the SAMHSA model, you're looking at a 2-person team with a clinician and a paraprofessional, so hopefully a certified peer support specialist, somebody that's able to go ahead and take on that role. So there are differences in both of those disciplines, some significant differences. So we really want to make sure that we're understanding what the team dynamics are, what makes a good team, what makes a successful team, some of the challenges we may find out there in the field when you are working with somebody other than just yourself. And how to go ahead and navigate that. Because what I can tell you is that what causes people to quit in mobile teams often isn't the actual job and the working with folks that are in crisis. It's disagreements with their partners, or secondarily, disagreements with their supervisors or not getting the management that they need. We need to go ahead and train to our transportation guidelines. SAMHSA does talk about we should be transporting voluntary folks when it is safe to do so to higher levels of care, as opposed to requiring law enforcement and police. Happy to have that discussion after the meeting to talk a little bit more about that. Certainly, we need to talk about self-care For those of you who are working crisis or working with crisis staff, you understand the level of work does cause an increase in burnout. I was actually having lunch today with the CEO of one of the larger public inpatient psychiatric hospitals that work exclusively with court-ordered evaluation. They've got a turnover rate for first-year nurses coming into their field of 70%. I mean, 70% of the new nurses they hire are gone in that first year. So we need to really support our staff in self-care. And most of us, while we do a good job talking to others about how they can do self-care, don't always do a good job for ourselves. And finally, and you may spend a lot of time on this, especially with California, what is my involuntary care processes? When I need to put somebody on a hold, when I need to take away their constitutional right to freedom, what does that entail? How do I do that? What supervision do I get? What is the state mandates? When can't I do it? When can I do it? What is the process? What is the policies? How do we make that happen? Because what you don't want is you don't want staff out there overprescribing 5150s. You don't want them underprescribing 5150s. You don't want them doing it erroneously. You don't want them doing it wrong, because there's just so much liability that tends to go into that. So that's something we spend a considerable amount of time on. So let's move forward. So as far as the training timeline, I've known a lot of mobile teams that did this a ton of different ways. I'll just tell you really what we did. And I think it works. I liked it. It was some evolution. But we would do about 3 weeks of crisis theory and mobile crisis outreach team specific. It'd really be about it'd be about 2.5 weeks if we really broke it down. And that's classroom. That is modules. That is having one of our leaders or one of our better, I'm not going to say better, having one of our staff that tended to have better key performance indicators or benchmarks and metrics go ahead and do the trainings. And it would be about 2.5 to 3 weeks of crisis theory, mobile crisis outreach team. I'd throw in about 3 days of agency specific training in that. So after I got them from HR, it would take about 3 weeks before I was ready to put them on a full team. And what I would do then is for 3 weeks, they would shadow a full team. So they're going out as a third person on that team. They're watching what the clinician does if they're a clinician. They're watching what a peer does if they're a clinician. They're watching what a clinician does if they're a peer. They're watching what the peer does if they're a peer. So for about 3 weeks, they're shadowing a full team, and accountability for what they learn and don't learn at that point and how they apply it comes back to those team members who hopefully are some of your best and brightest and really good at what they do. After that 3 weeks, I go ahead and I flip the script a little bit, and they become the primary on that. So if they're a clinician, they're a clinician on that team with a veteran peer, with a veteran clinician that's kind of hanging in the background, making sure that things are safe and able to debrief after every intervention. If they're a peer, they're the primary peer on that team with a veteran clinician and a veteran peer that's able to go ahead and oversee that and process every intervention after as well. So really by the time they're on a team by themselves, it's just a 2-person team, they've got 6 weeks of being a 3-person unit and about 3 weeks of training. So that's 9 weeks. That is significant. And I do understand that as you're hiring and as you're bringing people in, it always sucks when someone gives you 2 weeks of notice, and it's going to take you a month to get somebody for that position. And we're talking about 9 weeks of training, which means that as you're thinking about training, you need to think about having a vibrant staff of pools and part-times that can fill in for those particular times. During that first year, basically, I do performance evaluations every 3 months. So I'll get 4 of them in the first year. After that, I go to annually. And those performance evaluations have to happen. Are they getting better? Are they not getting better? Do we see a light at the end of the tunnel? What are their strengths? What are their weaknesses? What are their goals for the next 3 months coming up? And we need to have increased supervisor check-in. And while they're out there on the team, their peer on the team, if they're a peer, or their clinician on the team, if they're a clinician, is providing direct feedback after every single intervention. But instead of meeting with staff once a week, like I would do with a normal team, I meet with that staff twice a week if possible. And that always becomes a little bit more difficult because they're out on teams, or they're out actually on calls. So just as we kind of start to think about, realize I can go ahead and spend less time on training. What I do tend to see is the more training you do, the longer people do tend to stay. They feel a little bit more comfortable in that role. But I definitely do understand the dynamic of, I don't have 9 weeks. I've got teams I need to get up and running. I might do a 2-week training with a 1-week shadow and frequent supervision coming in. You're going to have to kind of determine what your agency can and can't handle. What I can say is you're going to get more bang for the buck. You're going to get less recidivism or less burnout, less turnover if you do have a little bit more extended training time. So let's jump into maybe the last one. So one of the things, these are just things that I kind of, started thinking is, what did I wish I knew then that I know now? And one is start from zero when you've got new hires. I have, over the course of my career, been just dazzled with somebody that comes in and really talks well for a mobile team position. Seems like they've got experience, they're engaging, everything's great. In the first 2 months they're on a team, just nothing's working very well. So I've got to start by expecting that all of my staff that we're hiring in do not have the skill set that I need them to go ahead and have, regardless of how many years they've been in the field, regardless of how many degrees they have, regardless of what experience they've got, regardless of where they went to school or where their last work performance was. I just naturally assume they're starting from zero. We're going to need to give them all the skills that they need. When you're starting to interact with peers and clinicians, one of the things that does tend to happen as you're thinking about training is if you are working with peers that are, a year, 2 years or less maybe into the field, this may be their real first professional interaction that they've got with licensed clinicians, or some of the expectations that you're going to have over mobile teams. So just start to think about it, and I'll give you one of the examples of not training maybe so much, but just looking at staff. One of the ways that I tend to look at if my staff are getting burned out or not is how many vacation days they have. If they have got 2 weeks banked, 3 weeks, 4 weeks banked, and every year they take two-week vacations, they stay with me for a long time. Conversely, if I've got staff that get 8 hours of vacation every 2 weeks on a paycheck, and they take those 8 hours the following week, and they've never got more than 4 to 6 hours in the bank, because when they get to 12, they're taking it, that's usually a sign of burnout, but it's not for peers. I've seen peers that have gone years and years and years like that. They just tend to maybe use their vacation a little bit different than other staff are going to go ahead and do. So understand as you're starting to work with peers and clinicians on a team for the first time that, how you may train, how you may go ahead and kind of oversee, and some of the traditional rules don't apply. You've got to be a little bit more flexible. Application of principles is more important than memorization. Really, it's how they work in the field. I can teach patient engagement or client engagement, but I need to see them actually utilize it. If they talk back theories, if they can tell me what AIDIT stands for and what each element means and why it's important, that's great. But if they're out there in the field and they're not developing a therapeutic alliance with somebody, they're not developing the rapport needed to help that person move to the next level, memorization and being bright has absolutely nothing to do with it. I need to go ahead and see how they apply those principles. What I like to do is if I've got staff that are really good and you've got strong staff and you've got weak staff, I like to make sure that my strong staff are training new staff. I think it's a perk for them, and I'm always looking for new challenges and new opportunities for my best and brightest, because it's not always about being able to be promoted, especially in smaller agencies. So I like to go ahead and give them a little bit more challenge and kind of move them up, but also they can actually talk from a much more practical viewpoint about what skills you need, why you need it, and when you go ahead and utilize that from a way that's going to be much stronger. You want to find ways to bake in the trainings. So I'm going to assume a lot of you have been through trainings before that you never utilized. You went through it to check off the box in the new employee orientation or hiring or onboarding process and never used it again. So as you're thinking about your trainings, think about how I tie that into supervision, how I come back to the training and what they should be doing, back into that supervision, and think about your annual appraisals, not just whether or not you are have completed your required training, but whether you're actually utilizing those applications of those principles. So every week that I'm talking to my staff, I'm talking about how they're applying their training. Every year in evaluation, I'm talking about how they're applying their training. And periodically check your culture in relation to training. Once again, if you're checking boxes because you've got to get on board and get somebody in a van and get them out in the street, you can do it. People do it. I see it all the time. But your training then isn't a benefit. It's actually more of a hindrance. So if you're coming at your training from a viewpoint of frustration, sadness, and feeling like it's just never going to go ahead and get better, probably you're checking boxes. got to think a little bit more about ways that you might be able to support getting that training so it's actually a benefit. Are you doing the right trainings? Are you doing the wrong trainings? Are you doing the right trainings for too little time or too long of time for the wrong? And really just try to nail it down to a point that you feel your trainings are valuable, impactful, and are going to actually help your teams perform out in the field. And then it becomes a necessary evil that you're actually excited to do because you know the outcomes that you're going to go ahead and get. So today, really the focus that we kind of have is a little bit more on Q&A and questions, and I'm happy to go ahead and answer any of those.
We'll start off with Steve McNally. I believe Steve had a couple questions. One's in the chat. It says, on law enforcement, how do you approach jurisdictions to motivate to change policy? Armed, uniformed officer comes to door with therapist. Can you direct me to a link or presentation? My understanding is that each sheriff or police chief sets policy. Is that correct?
So yes, I'll talk just briefly about law enforcement interaction because I think it is absolutely important, and I may ask for a little bit of clarification. So if we take a look across the country, there are really multiple types of mobile teams that are out there. One I would call an embedded model, and what an embedded model means is Jamie's a clinician. I'm going to go jump in the car with a deputy or an officer, and we're going to go roll on each call that's coming through. Whether or not I need somebody with a gun on scene or whether I don't need somebody with a gun on scene, they're coming with. The second is what we would call a co-response model, which means, yeah, I'm Jamie. I've got a van, and police, I'm going to go to where police are to provide support. So 911 may dispatch an officer, they may know it's behavioral health, I'm going to roll, but I may work with 5 different officers over the course of my shift, whereas if I'm embedded, I'm working with 1. And then really what we would look at is the Crisis Now model, which would be the civilian mobile response team, which is going to be 2 clinicians, or a clinician and a peer, going in community, not involving an officer unless there is a situation of public peril, which quite frankly is about 3% of the time or less if we start taking a look at national kind of data for agencies that do this a lot. So the question about it is each chief is going to really prescribe how he wants his uniformed officers or deputies to go ahead and respond in the field. They're going to have different ways that they tend to view it. So if I take a look at a lot of communities, there is a lot of public relation positives and benefits about putting social workers in cars with police. When we start talking about defunding law enforcement, there's a way to think about shifting that funding into more of the behavioral health co-response model coming through as well. So if we need to change law enforcement's viewpoint of how to run that, a couple of things do come to mind. One is I generally don't do it myself. I bring police with me that have a mindset similar to mine. So how it works for us is Nick Margiotta, who's a retired Phoenix police officer, ran CIT program here for 11 years. I would call him and say, I need to go meet with Sheriff Billings at this county to go ahead and talk about a civilian response model versus a co-response or an embedded model. Would you come with me and talk cop to cop? Or I'll bring Sabrina Taylor, who's a current sworn officer in the Phoenix Police Department, currently running the CIT liaison, to go ahead and do that as well. So if I can bring a like-minded agency to go ahead and give comfort to a police chief that yes, it's okay to go ahead and run a different model, that works much better than me doing it. Second, I will come back to things like SAMHSA's national guidelines, which talks about the preferred model as a civilian mobile team and only incorporate law enforcement when there is an issue of public peril. So somebody's waving a baseball bat, somebody's identified they've got a gun on the phone book. I've got a 125-pound Doberman Pinscher that, you know, is trying to get out the door to get to me. These are some of the things that obviously the public's in peril. I need law enforcement to come, but that doesn't mean they should be going to 100% of the calls out there. So I start off with cop-to-cop discussions. They're going to trust another officer, especially somebody who's worked the streets much more than they will a clinician. And then I go back to what the research tends to show, and then what the national guidelines tends to be. And if that fails, I will have them actually talk to jurisdictions in Arizona that runs this model very successfully to give them an opportunity. But once again, you can't force them to do what they're not going to go ahead and do. And sometimes we need to just understand it may not be the right time, and we need to
It's less the police and it's more the healthcare agency, I think.
It's more the health agency?
Yeah, they want the safety of somebody at the door with them. You know, the sheriff who's on the Mental Health Service Oversight and Accountability Commission will say that a lot of jurisdictions will have police not in view, but nearby.
Staged.
And then our county has, we have the Whitebird thing from Oregon being paid out of CARES Act by cities. We have a CAT team. We have a PERT team. All funded from different places and none of it funded from the current funding that's available from the state, which is, so if a 5150 happens, then the police will be coming because that's the way it's set up.
Yep.
But the police really don't want to be in this business. And I've heard Cahoots explained as it's great for phone diversion, but not necessarily for, you know, helping people through unless you have a really strong backbone. And then I don't know if that's true or not. And then I know in LA, they have an officer with the dispatcher and they're coordinating, figuring out where the person's connected or not connected. Is it safe on scene? See the, you know, talk to the family first. So as soon as they get there, they know there's no problems. But, you know, families too need to be trained because it's, when it's a 5150 or a CAT team, you know, they have this, this feeling like something's going to happen when rarely something is going to happen in California. So I think
there's a lot to unpack there, Steve, and you're absolutely right, but it may be a little bit easier working at it from that viewpoint because we can generally have an easier time changing mental health professionals' viewpoints than we sometimes do with law enforcement who
okay.
Very, very protocolized. But here's the concept. So the first thing I look at, if I've got a team that is overutilizing law enforcement as security, not even as safety, but they're just security. I start looking at my staff members and going, is there something inherent that they're frightened at the work? And I will see that. In Maricopa County, I'd run mobile teams where a team would call for police backup or support 7% of the time. And I would have teams that would call 0% of the time. What I can tell you is in Maricopa County, and your county is going to absolutely be different, but in Maricopa County, the right number is about 3 to 4%. So over the course of a month, if somebody has 7%, I'm probably not worried about it for that month. If it's 2 months in a row, I probably need to evaluate. And really what I start looking for is, are they calling police every time someone has a diagnosis of schizophrenia? Are they calling every time they're going into South Phoenix for police backup? Are they calling every time somebody's intoxicated? You know, crisis work, you need to be a little bit comfortable in some awkward situations. But conversely, the other side of that is if I've got a team that hasn't called for police backup in 2 months, I'm actually more concerned. I'm very concerned for them because they might think that they can handle everything. You know, I can't have cowboys and I can't have scaredy cats. I got to kind of figure out which is which. I need those folks that are making good clinical judgment, bringing police in only when there is an issue of public peril. And we need to discuss that. So as you're thinking of your teams, realize that if you're going into a new, if you haven't been doing this for years and years and years and have role models in there and starting, the percentage of times they believe they're going to be unsafe is huge. Street level work is scary work. You know, you've got to get kind of used to it. You've got to be able to determine the difference between danger to others and scary to others. And in fact, you've done it a while, you've done it a while. So what we've tended to see in other communities, it's the police that start to push back. They say, look, you have us come out for a 60, 75-minute intervention, and we're just kind of sitting there. And the last 25 times you've done it, there have been no issues. And I don't know if it's been no issues because we've been there or just because there was no reason for that issue to go ahead and happen. But I do think it comes back to training. I need a 2-person team. I need the right 2 people on that team. I need to have my safety protocols down so that they've got a radio, they've got a panic button that they can go ahead and hit. And I need them to be able to make determinations in the field or en route that is going to be, is this safe or not safe? And then as leaders, I need to go back and be able to evaluate that. So if I got somebody that's got 7% 2 months in a row, I'm looking at what they saw going out. Did they call the police based on the initial dispatch, which said drunk 240-pound guy, you know, with, you know, diagnosed with bipolar disorder? And are they just calling for cops based on that? And if that's the case, there's some supervision that we can come into. If somebody says they've got a gun on the phone book, yeah, you're going to be calling cops. I'm never going to second guess what you call the police for that one. But that does come back to if I got the right people on the right bus facing in the right direction in the right seats. And that usually is easier to change than police. But usually the reasons you tend to change is police at some point start pushing back really heavy on that.
I appreciate you tying in looking at the outcomes and the trends and seeing, okay, when is police being called to come in, and then kind of connecting those dots to determine, okay, what's most appropriate based on what we know, whether it's that 3 to 4% where it's reasonable, connecting those dots.
So, I mean, and there's two things to think about when you use data. So the reality is, when I was running mobile teams here, we'd go out 1,800 calls to 2,100 calls a month. So we're going out 60 times a day, 60 plus times a day. So it's tough to know what each team is doing all the time. You do your ride-alongs, but you might get one ride-along for every 30 times they're out in a call, that you're going out there with. So you do manage with data, and you've got enough data to start to take a look at. And you may decide, once again, in Maricopa County, it's 3%, it's about that 3 to 4% is that right number. In your community, it might be 7 to 14, it might be 20 to 30. You're going to have to kind of determine that for yourself. But when you start looking at big data in aggregate, you really start to identify what your teams are doing, and where we need to go ahead and start to move into as well. And you may decide, I'm going to give more leeway to the overnight team for calling for police than I might for the 9 to 5 shift, just because, yeah, it's probably scarier. I could look at documentation saying, well, I'm going behind the Circle K, but I'm going at noon on a Friday. Probably better than going behind the Circle K midnight on a Friday. I could see that might amp things up a little bit, and I might start looking at my staffing as well. If I've got, 2 smaller, staff that maybe they need a different partner to feel a little bit more secure, and how those things tend to work. But what I can tell you, safety is the number one thing that I hear when new teams are starting to come up, that they don't believe they can keep themselves safe. They believe everything is potentially dangerous. The data doesn't show that. We're not seeing a lot of adverse actions out there with mobile teams out in the field. Once again, use your best clinical judgment. The other thing about safety is very few people will chase you to hurt you. We're not commanding or demanding anything. Someone tells me to F off as I'm walking up to them. Okay, I'm going to stand back here. Very few people are going to chase you back to the van because you're not a threat to them at that point. But it is that training aspect of it and finding the right people. Crisis work's not for everybody. It just isn't. It is for me. I love a little bit of adrenaline, but it's not for everybody.
You are able to request no cost technical assistance with the CARE TA Center, specifically with RI International and Jamie Seller. If you have additional questions around how to build out your mobile crisis unit team, if you have additional questions around training approach and some of those issues we talked about around when to bring in training appropriately for when to bring in law enforcement and other issues. So if you have any questions or would like to have some individualized assistance with that, we absolutely welcome you to submit a TA request. Thank you again. Take care. And we hope to see you in the next session.